This is a big deal, and I'm very honored and proud to have been asked to speak on such an auspicious occasion to celebrate the accomplishments of residents who are going to take the reins from people like me. I'm a lot closer to the end than I am to the beginning, and I envy you because you are at the beginning of a fabulous journey, which I hope will be long and prosperous and fulfilling for you. And when I say prosperous, I don't just mean economically, I mean in all ways. I'm here to talk to you about a very serious subject, to talk about medical errors. And you know, it's very interesting. If I say medical errors, people will come up to me and take me to task and say, "You're not always talking about errors, are you?" And I'm not. Often I'm talking about complications that really don't speak to errors. But many of us absorb, when something bad happens, we think we're looking to see what we did what that was wrong. And if you happen to operate in a blame culture, and some of us unfortunately are in the midst of a blame culture, then you can't help but start looking. Who was at fault? Who was sleepy? Who was not effective? Who was not on the ball? And I maintain that that's kind of the wrong approach. And I'm going to talk about what I think we should be doing differently these days. But I'm going to talk about some of the systemic and medical factors in the culture of medicine that I think contribute to errors, even though we are the most ethically grounded people on the planet. That's my opinion. I'll talk about personal factors, cognitive factors, sleep and fatigue. And then I'll get to that core issue of unhealthy shame, which I think is one of the major impediments to us developing an attitude of curiosity about our mistakes. Curiosity. It's very hard to feel curious when you're ashamed. And it's very, very hard to do that. But curiosity, if you develop it, that's the royal road to figuring out what's wrong and how to fix it. And I am going to talk a little bit about how to move forward. I have to have a competing interest declaration. I have lots of conflicts with lots of people, but none of them have anything to do with pharma. So I'm here to talk to you about the F word. No, not that F word. Failure. And I just wanted to position failure in the zeitgeist these days. There was a time when people didn't want to talk about their failures, and now everybody wants to talk about them. There's a conference called FailCon, and it's franchised. It's all around the world. In fact, I'm going to be the keynote speaker at a conference in Toronto in a week or so called July 9th. It's called Fail Forward. And at conferences like these, entrepreneurs will talk about how they dropped $500 million on a startup that they thought couldn't miss until it flamed and burned. And at the very least, they get a good speech. And people want to hear them be humble for a moment and also want to hear what they've learned. There's a conference of pastors called Epic Fail. They could have called it Biblical Fail. And it's a conference in which pastors get together, clergy get together and talk about some of their worst mistakes, the advice that they wish they hadn't given. Instead of listening, they kept telling people what to do. And it's very easy to say in those areas of endeavor, well, we're different, aren't we? You know, after all, not brain surgery. Heard that one before. Nobody died. And you know, when you start looking at the statistics, it can get really daunting to talk about failure. This is Baker Norton data from, actually the original data was gathered around 1999-2000. It was published about 2004. Estimated that up to 24,000 deaths per year due to preventable medical errors at Canadian hospitals. A gross underestimate, especially when you start looking at the data in the United States. Originally it was 100,000. That was the 100,000 deaths a year by the Institute of Medicine estimate in 1999, and then revised upward to 200,000. More recently, John James, who I had the pleasure of sharing a panel with at the Kennedy Institute for Ethics at Georgetown University. Imagine that, me, a doctor talking about his own mistakes, sitting next to two parents talking about losing children to preventable harm. It was a pretty hard panel to be on, but fulfilling in that there was definitely a meeting of the minds. John James not only lost a son to preventable harm at about the age of 18 or 19, he also happened to be a retired NASA engineer. And he put his engineering head together and reevaluated some of the data, and he has convincingly argued that the number of preventable deaths in the United States every year is actually closer to 400,000. which is, I think, according to the Sullenberger estimate, would be something like 40 jumbo jets crashing every week with no survivors. Now imagine the implications of that. More important than that, if you ask people who work in the system, nurses, hospital administrators, a large percentage of them believe that patients will suffer errors, will have errors during the course of their care, significant errors. You may remember from 2 years ago, the Fifth Estate, the CBC did Rate My Hospital. You know, forget the methodology for a moment. I think the most telling piece of information that I want to take from that was a survey of nurses. Roughly 1 in 4 of them, about 24% of them said they would not recommend their own hospital to their friends and family, which is a pretty telling remark. And I hope you don't feel that way about your hospital. I certainly don't feel that way about mine. Looking at some of the causes of errors just across the entire spectrum, they're everywhere. Medication errors, as many as 10%, maybe in this study 19%, certainly 10% in studies around the world, 10% of drugs, wrong drug, wrong dosage, wrong route of administration, wrong patient. In the United States, it's pegged at $2 billion annually. And you know, there are all kinds of these errors that have to do with the way pills are counted, the way medication is doled out through IV infusion pumps, allergies not taken into account. And you know, this isn't your bailiwick, but it does affect you. Certainly, you know, a lot of us think, what do pharmacy or pharmacological errors have to do with radiology? Well, pretty significant connection. Medical errors in radiology, same prevalence as in other settings, but 7 times more likely to harm patients. So yes, that's another one that you've got to be thinking about. Pathology, I only mention this one. These are just photos that show you people who've been directly involved in pathological errors and various provincial inquiries into errors in pathology reporting, biopsy reporting, from the Cameron inquiry in Newfoundland, in which there were errors in estrogen receptor, progesterone receptor determination testing. As a result, some patients were told they were ER, PR positive and got drugs like tamoxifen when they didn't need it. They were negative, and vice versa. And others where you have a pathologist who has been making errors for several years in determining whether there's a cancer there or not, what grade the cancer is. The thing about those kinds of errors is that they can be very hard to find without some kind of a look back or peer assessment system, and the consequences may take years to play out. You know, if a surgeon takes the wrong leg off, or you know, if a thoracic surgeon operates on the non-cancerous lung in the operating room, you kind of know it pretty quickly. But with some of these pathology errors, it can take a lot longer. And then, of course, I have to talk about, I customize this. So, you know, I talk about emergency medicine. I'll talk a little bit about that. But certainly, when it comes to radiology, you have your unique situations. And some of these have become quite prominent in that they've been discussed in the media. For instance, in February 2011, the CT scans of nearly 2,500 patients had to be reviewed due to significant errors in a radiologist reading films at St. Joseph's Hospital in Comox, British Columbia. And at issue, there were discrepancies in the CT scan interpretations, and another issue was how long it took regional health authorities to notify the province that there was an issue. A little bit closer to home and a lot closer in terms of time. You may remember December 2013, an external review of more than 3,500 mammograms and CTs found 11 clinically significant errors. By the way, does anybody know what an acceptable error rate is? That is, if we don't, then the reason why we don't is we're not curious enough about it. Or maybe we're afraid of comparing, we're afraid if we put our error rate out there, we're going to have to compare ourselves to everybody else. And everybody's kind of insecure. There's a lot of insecurity in the culture of medicine. We're afraid of sticking our hands up to answer a question in case we're wrong. Or maybe we fail to ask a question because we're afraid that if we ask that question, we're going to look stupid to everybody else because everybody else knows the answer to that question. Meanwhile, what we don't realize is that everybody's feeling exactly the same way. There are no stupid questions. A wise person once said to me in medicine, a mentor of mine once said, the only stupid question is the one you don't ask. So please ask them all, right? But, so I don't know. I don't know if 11 errors, I don't know. I mean, they treated it as a big deal. 8 of the 11 had been caught and corrected. 3 went unnoticed, and one of the most prominent ones that was unnoticed was that woman here who ended up dying of a cancer, which may or may not have been fixable, curable at the time that the original findings were missed. But, you know, there's no question if these get into the media, they will be talked about because it's not just us that has created this culture of medicine. It's reinforced by the media. It's reinforced by the public, this notion that we're never ever supposed to make a mistake. Just going through some of your common list of errors. The epidemiology of errors in radiology. Breast cancer radiologists are frequently sued for missed mammogram abnormalities. 30 to 70% of cancers detected at follow-up mammogram were retrospectively seen on the initial study. And all radiologists, including competent ones, have significant error rates. Lung cancers, only 50% of 1 centimeter lesions are detected on a plain X-ray. Missed fractures continues to be a significant source of negligence arising from emergency medicine care. And some of the largest payouts, however, so that's the numeric source of a lot of litigation, but large payouts, obviously, OB is second to none. Ultrasound, misreadings of ultrasounds, they will have the largest payouts for pretty obvious reasons. The most common sources of error, you have yours. A lot of them are cognitive errors, and we'll talk about those a little bit later on because they're really important. Observer errors, errors in interpretation, failure to suggest the next appropriate procedure, failure to communicate in a timely way and a clinically appropriate manner with the people who ordered the test, and when you can't reach the people who ordered the test, the patient. So we ask why. And I started off by saying that health professionals are among the most ethically grounded people on the planet. And by that I mean they have a very strong sense of right and wrong. And they're the kinds of people who, on the way out of the hospital, did they forget to check something, they'll turn around and walk back into the hospital to check. Or the person who wakes up at 3 in the morning. There's a psychologist in British Columbia who has a lovely presentation. He treats health professionals in burnout and compassion fatigue and moral distress and all of those kinds of issues. And the title of his talk is The Patients You Sleep With. He doesn't mean it in that way. What he's talking about are the patients who wake you up at 3 or 4 o'clock in the morning worrying that you missed something or that you didn't take that second look. So yeah, we're there. So it's not because we don't care, and you can listen to, and I'd like you to hear a little bit of tape of, because I brought it along, and I think it's good to not just hear me. There's a saying in medicine, you never forget the names. You can do 50,000 procedures, you never forget the names of the ones who have the complications. And that was certainly true of these 3 surgeons who I interviewed on my show on White Coat Black Art. Ellen Anderson-Penno, an ophthalmologist in Calgary, David Amiro, an orthopedic surgeon in Halifax, and Jack Barkin, a urologist in Toronto. So have a listen to what they told me.
I actually missed a meningioma for a period of time. The patient came in repeatedly, kept telling me her vision wasn't quite up to snuff. Things looked quote-unquote flat. I looked, I did tests, I did visual fields. I could not find any objective findings other than her complaints. Finally, the family doctor and I talked, and he said, well, let's just scan her because she just keeps complaining. And she had a rather large meningioma in her orbit.
Which is a tumor.
Yes, and she, the outcome was generally good. She had surgery, but that deserved a big apology on my part because although I couldn't find anything, I wasn't listening carefully enough to the patient's symptoms, and it took me a while to respond.
I've had a number of complications over the years, particularly the trauma patients. You often see they come in and they have a lot of injuries, and sometimes the surgery doesn't go as good as you thought it would go, particularly if you're started at midnight and you're working all night. I think that the biggest thing, however, is that the patient and the patient's family will forgive you what you tell them. They will not forgive you if you don't tell them or if you make something up. And I think it's the measure of the person to come in and admit what happened. And often they're fairly forgiving, I find. That seems to be my experience.
So you're in the room there, and you're talking to the patient after something's happened, something bad has happened, and you're telling them, sorry. What's that like?
Horrible.
Yeah, it's the worst thing that can possibly happen when something unexpected happens. We, with all of our diagnostic techniques and the workup that we do on patients, rarely are we surprised when we get inside. Sometimes things just fall apart. You know, the patient doesn't heal the right way. He's got an extra vessel here or there that you did not see, you would not have known about. And no surgeon is uncaring. And sometimes people believe that surgeons are, very strong and this type of thing, but we are very attached to the people that we are dealing with, and we want to make sure that we do the best we possibly can. So surprises like that are very, very devastating.
Yeah,
And those are probably the patient names you remember. You may have done 2,000 surgeries, and you remember the names of the ones that had the complications.
And at least one of those stories or one of those surgeons was talking about what sounds like something bad just happened, and the family might be asking, well, couldn't it have been anticipated? Maybe it could have, maybe it couldn't have been. That doesn't sound like negligence to me, but on the other hand, a very esteemed colleague talked about the day that he was doing open heart surgery with the fellow. Completed his residency, and the fellow was taking extra training in cardiac surgery. And there was a point in the procedure when a catheter with a balloon had to be threaded through a valve, a heart valve. And in the esteemed colleague's experience, of course the fellow was doing it, in the esteemed colleague's experience, that catheter was supposed to go in like butter. And he could see that the fellow was having difficulty putting it in and seemed to be encountering some resistance. And in one of those moments that will be in his mind for the rest of his life, somewhere, he resisted the urge to take over, and the fellow needed to learn how to sort his own problem out. Well, he forced that catheter in, and very soon the entire field was filled with blood. And they worked feverishly to try to control the bleeding and stop it, and the end result was that they weren't able to. And I invite you for a moment to think about, this is somebody who told this to me after I had given one of these speeches. Many people I know have a story like that, maybe 2, maybe 3, moments that they're not proud of, and it's not an accident to me. You cited the article that I wrote in the Globe and Mail. This is one of the factors that will be a contributor to burnout, certainly to trauma. It has been said that there are 2 victims when it comes to medical errors or even complications that turn out to have a finding of negligence. The first, of course, is the patient, and if they've died, their family. And if it's a patient who can no longer work, certainly their family will be directly involved. But the second victims are often the health professionals who are directly involved. And if you've ever been through the procedure, the whole process of being sued, the college complaints, maybe the college says you didn't do something as well as you should have, gives you a verbal caution or written caution. And the M&M, it's anonymized for whose benefit, and I'll get into that a little bit later on, but you're sitting there squirming, unless you're in a positive culture where it's so good that people are saying that was my case, and they talk about it, and there's not a trace of defensiveness about it, but it's not uncommon for the second victims to be the people who were directly involved in the error. So I hope we put to rest the notion that this isn't something that we would take 2 or 3 years off our lives to undo if we could. So what are some of the reasons? What are some of the factors? You have your world, I have mine. I'm not going to pretend to know your world, but I sure know mine. I certainly know in the emergency department that we're seeing more patients than ever before. The time pressure is a real problem, that often I have 10 minutes or 12 minutes. That's the aliquot of time that I have. And it's not that at 10 minutes I stop seeing this patient no matter what. I don't know what's wrong with them, but I'm moving on to the next patient. But that I'm spending 12, 13, 14, 15, 16, 17 minutes, and I know in the back of my mind they're just pouring in. And it takes a lot of discipline to be able to say, let them pour in. Now we have a system with a backup. Let the backup come in. You don't want to be known as somebody who's not a slacker, but somebody who just can't, the expression is move the meat. That's what we call it in emergency medicine. Back in 1984, when I started, 70 patients a day, about 26,000 patients a year. Now we're up to about 60,000, and we're heading towards 80,000, and they're older and they're sicker, and they don't speak English, or they have dementia, they can't give a history, and we're constantly distracted. We used to be able to run out to the phone. Now the phones are with us, and they're interrupting us constantly. And the economists, the expression that the economists use to describe this is productivity pressure. And it's hard to find a frontline worker in healthcare these days that isn't experiencing productivity pressure. Now, you've probably heard, this is the famous Swiss cheese model, James Reason's model of accident causation, in which there are several events along the way that start with the first mistake, which is represented by a slice of Swiss cheese, and gets propagated or does not get propagated into an injury, what's called losses in your bottom left. For instance, in my sleep-deprived haze, I see a patient with alcohol withdrawal, alcoholic ketoacidosis, and I ask, in my brain, I'm asking for diazepam, but what comes out of my lips is diltiazem. And most of the time, a nurse looks at me and says, Brian, and that's the end of it. And we correct the error right there. She corrects the error, he corrects the error, and the patient gets diazepam, no problem. That first error gets propagated, according to this model, into a loss when the holes line up in the Swiss cheese. Some people might call it a perfect storm. And the importance of this model is to state categorically that harm that happens to patients is seldom one person's fault. Even taking off the wrong limb or operating on the wrong lung. There are a whole bunch of other reasons that can contribute to it. But is that what we really think? And I don't think it is. I think most of us today are afraid that if we attribute errors to a system, that we are demonstrating that we dodge personal responsibility for our mistakes. And I guarantee you, if you're called on the carpet by a chief, and I know what that's like, because it's happened to me more than once, you're going to sit there and wear the mask of shame most of the time. Now, some of us are very good at arguing, at coming out with well, can you prove that happened, and citing a paper, and some of us are better at that than others. But a lot of us, when confronted with that kind of a situation where there seems to be a concerted effort to find someone to blame, will know that one of two things. Either you sit there in humility, wear sackcloth and ashes, and accept the mantle of shame, the mask of shame, the garment of shame, whatever you want to call it, or risk being labeled as somebody who doesn't get it. And if you don't get it, then that's a pervasive problem, could be a personality problem, and that's the kind of thing that the college sinks its teeth into, somebody who doesn't get it. So most of us, in my opinion, and this is my opinion today, pay lip service to the system-based approach a lot more than we believe in it, other than the human factors engineers, and if they're here, I apologize. Most of us believe that taking personal responsibility trumps every other consideration. We rarely talk about our own mistakes with colleagues. Disclosing one mistake today is easy because we all get a free one every once in a while. Disclosing a second mistake 3 weeks after the first one is a very risky thing to do in the culture of modern medicine. How does the system cope with complexity? Rules. You can, you can't. I know we're going to create a rule that will prevent this from ever happening. And there are rules that are very, very helpful. And I will say to you that one of the reasons why we make as many mistakes as we make in the lean culture, I'll spend a couple minutes talking about that at the end. How is it that fantastically trained, dedicated, competent people can do superbly well today and can screw up tomorrow? And I think a lot of the reason for that is that we don't have procedures. We actually have not turned things that we do all the time into procedures that if we had them, we would stop making them up as we go along. We spend a lot of time making things up as we go along. And to that extent, checklists can be very helpful. And this is the surgical safety checklist that was first developed by Atul Gawande, World WHO. And you know that there's controversy about this. There are suggestions that properly used, properly trained individuals working in a hospital setting, that the surgical safety checklist can reduce errors and reduce certainly wrong side surgery, wrong patient, and can reduce mortality. Of course, you're also aware that my friend and colleague David Urbach led a study at ISIS in Toronto that threw a little bit of cold water on the concept of the surgical safety checklist. The principle is that it's your extended brain. It reduces your need to remember everything at all times of what to do next. And there may be a training issue. They may have picked the wrong time, the wrong model to have, I think it remains to be seen. I think we need to see more data. But even in a perfect world where you execute the surgical safety checklist, you're still going to have situations like this. April 2011, a Portland ophthalmologist operated on the wrong eye of a 4-year-old kid, and there's supposed to be a mark over the correct eye. It was covered up before surgery, so they didn't see which side. The ophthalmologist admitted that she lost her sense of direction. That's a direct quote. And my fear here, or my prediction, this has kind of happened, is that the researchers will immediately swoop down and note what was not done correctly and say, well, it just wasn't done correctly. And so, for instance, when you're doing an operation, you want to make sure it's the correct side, where side counts. You do a pre-procedure verification, you mark the surgical site, and then you take a timeout. And so the first analysis, the instant analysis, is that 72% of wrong side mistakes occur due to a lack of a timeout. And I can just hear the answer to that timeout. We'll extend the timeout. We'll have a second timeout. And if that fails, we'll have a third timeout. And anybody who thinks that there is a simple solution to that, and I'm not saying it can't be solved, but doesn't understand the psychology of the people who work on the front lines. And I'm not saying that this is an unsolvable problem, but that it doesn't lend itself to an outsider's solution. It's probably something that would be best worked out on the ground. And I want to talk for a moment about the medical mind. So far I've talked about the system. We're going to move towards the individual. And I want to talk about a concept that the psychologists refer to as the normalization of deviance. And basically, it's the answer to the riddle, the age-old riddle of why enough of us don't wash our hands often enough. And I'm sure you do. But I've certainly, there are hospitals in this country where the hand washing rate's been as low as 35% among physicians who ought to know better. And there are places that have hand washing rates as high as 90 or 95%. There are high-tech solutions, low-tech solutions to try to deal with that. So why is it that we don't wash our hands if we've been told to do so? And I want to play a little bit of tape of this guy, John Banja, talking about that. John Banja is a medical ethicist at Emory University, wrote a book with an intriguing title, Medical Errors and Medical Narcissism. Some of the reasons include productivity pressure, we are in a hurry, but I want you to hear it from him because I think he's got some interesting things to say and he's got a handle on the human condition.
A lot of healthcare professionals will say, I think all this infection control stuff is nonsense. It's just inefficient. Some of them will say, by the way, that my hands get irritated when I wash them all that. Others will say, I just can't remember to do all that. Another reason is that these measures are not being enforced by hospital leadership. People may not know what the rules are. The rules oftentimes change. Standards of care change. Also, you have people who are very stubborn, especially I think the older you get, the more stubborn you get. It is hard. For example, we are introducing new technology all the time. Where you introduce that technology, you naturally invite a learning curve. Some people, especially with modern day technologies, computers and electronic medical records, they're not very good at handling that stuff. They'd much rather write things down in their spiral notebooks, which they've been doing for 20 years. So it's getting used to that unfamiliarity that a lot of people find difficult. And then there are other people who just simply don't follow rules because they believe the rules don't apply to them.
What do we call them?
We might call them narcissists. or at least that they revert to a kind of a narcissistic type of I am over and beyond the rules. I am not beholding to the rules. I am special.
And do you know what we call them? We call them rebels. And we like rebels. We like mavericks. There's an honored place for mavericks in healthcare, and sometimes mavericks do good things. But I wanted to highlight this. You don't wash your hands one day, you're in a hurry. You step into the room, and you see the patient, and nothing happens. You do it a second time, and nothing happens. By the time you've done it 3 times, the new procedure is I don't need to wash my hands anymore. It's that simple. And the significance of it may not be clear when we don't wash our hands. I mean, clearly, if a patient died 24 hours later of C. diff, then we'd know about it, but we don't. And that's kind of what happened with the Space Shuttle Challenger. And you may remember it. Residents are not going to be old enough to remember what it was like. Like for me, I remember where I was when I heard that the Challenger shuttle blew up. And there was, there were lots of blue ribbon panel investigations. And at the root of what happened there was the normalization of deviance. And that's what happens when you fail to follow a standard procedure and you adapt the procedure, maybe because of productivity pressures, maybe because of external factors, and it's not just the one person's fault. It may be the external pressures were too strong. So it's a gradual shift in thought in which the non-standard or unacceptable behavior and standards becomes acceptable. And this is, when they did the investigation, they found out that the fuel inside the solid rocket booster down here ignited and blew up the shuttle. And the solid rocket booster is not one solid piece. It's a bunch of cylinders that are joined by these O-rings. And the O-rings were rated to work at 50 degrees Fahrenheit. What is that, +4 Celsius? No, +10, about +10 Celsius. And one day, they had a launch at 48 degrees Fahrenheit, and nothing happened. And then another time, they had a shuttle launch at 45 degrees, and nothing happened. And soon, this became the procedure, and down and down and down it went until that fateful day in January of 1986, when the ambient temperature was 29 Fahrenheit, about -1, -2 Celsius, and that's when the O-rings failed, and that's when the Challenger blew up. And so this is often what's behind many catastrophes. So I want to talk about us. Here's another factor that we have to deal with. You have to deal with it just like I do, sleep deprivation. And I could spend a lot of time talking about the impact of sleep deprivation. It's actually very controversial. The standard, and it's kind of become, not standard, dogma, is that 17 hours of continuous sleep deprivation is equivalent to alcohol intoxication. And certainly the studies of residents have suggested that at least, they're not the highest quality studies. I would refer you to what John Frank has done, the study that was commissioned by the Royal College of Physicians and Surgeons, because I think it's revealing. Certainly, but I put this out there to tell you that that's what the public thinks right now, that sleep-deprived residents are unsafe. And in fact, I'm going to headline a panel at ICRE in the fall. Not headline, I'm going to host a panel of experts, and we're going to have like a town hall meeting, is a tired doctor an unsafe doctor? You know what the response has been to these concerns, and that is to gradually reduce the number of hours that residents are up consecutively and to reduce the number of hours they work per week. There have been far more drastic reductions in Europe, and we're starting to get some data which suggests that the fix may be worse than the disease. Surveys of residents finding that they're not happier with the fewer hours. They're also getting a lot more handovers, which are probably not good. That was the headline story in the Globe and Mail a week before 2 weeks before my address, which I talked about. And there are great concerns that residents who have reduced hours and have to go home are actually seeing fewer patients and gathering less bedside clinical experience, operating room clinical experience before going out into practice, which obviously is a big problem. And patient and trainee welfare is still being compromised. I wanted to talk about, I want to make sure that I have time for questions. I do want to talk about cognitive errors. And if you've not read this book, How Doctors Think by Jerome Groupman, who's he's a physician, an internist medical writer. This is a bestseller of a few years back, 2006 or so, 2007. Basically, he took the work of my colleague Pat Crosscarry and popularized it. Pat Crosscarry is an emergency physician in Nova Scotia who's also a PhD in psychology, took cognitive psychology and applied it to the behavior and thinking patterns of doctors. And you've got your experts in radiology, but he certainly has a handle on emergency medicine. And he unpacked, I played for him this tape that I'm going to play of Bruce Campana, an emergency physician at Victoria General, talking about a classic error and these are errors with disastrous consequences for a patient. So have a listen.
Some poor guy come in that was autistic. He's about 30 years old, and he was brought in screaming and violent. And he would try and reach out and grab people. He was a large male, and people were afraid of him. And the care home came in and said, look, he always gets like this when he's constipated. Can we just give him an enema and get out of here? So we gave him an enema, and actually I got a big guy to try and disimpact him. And the guy was screaming and yelling, and the care people said, look, this always happens. Can we just take him home? So he went home, and then I came in for my next shift. And you know that feeling when you come into the shift and somebody looks up and they say those fateful words, do you remember that patient you saw last year? He's dead. And he, of course, had a ruptured appendix at the autopsy. And, life doesn't make sense sometimes.
It actually does if you have an expert in cognitive errors. And Jerome Groupman, we played that tape, and then I had him analyze the errors that he saw in that case. Oops. There we go. Too fast with the finger.
First, let's start with what's called a framing error. So this man, this 30-year-old autistic man, is put in the frame of constipation. He's often constipated. We also have what's called an availability error, meaning that what first came to mind is the diagnosis that occurred in the past. He's been constipated in the past. This is the same pattern, so it's the same thing. That's what's most available in your mind. That also causes a cascade of what's called diagnosis momentum. It's like a boulder rolling down a hill, gathering force. This is what it is, this is what it's been in the past. There's also what's called an attribution error, and this is on the emotional side. We tend to find difficult patients, difficult to handle, perhaps people who we can't connect with emotionally, like autistic people or mentally ill people. We don't like them often when we're physicians. They make our lives much more difficult. There's no way to get a history from this man. So we're more apt to quickly attribute whatever is going on to the stereotype that we have, which is a flailing, constipated, autistic man, and we want to get him out of the emergency department as quickly as possible. All of those factors in thinking and feeling coalesced to cause this tragedy.
The good news about understanding cognitive errors is that you can address them. Everybody has their cognitive biases, and you can ask yourself, am I about to make that mistake? Am I treating this patient with throat pain in the ear, nose, and throat chair differently because they were placed in the ear, nose, and throat chair when could they have angina? And you can, and what we want to be able to do is create a framework where people feel free to enter that state of metacognition, where they are thinking about their thinking, and not in a rumination type of way, or an obsessional kind of way, but asking the question, what else could it be? If we're wrong about this, what else could it be? What's the worst case scenario? And you can't guarantee that you're going to be able to prevent these from occurring, but we have a saying in the emergency department, geography is destiny. If you put a patient in the resuscitation room, you're going to treat them differently than if you put them in the ambulatory care room. My fear is that we go to the talk, the annual talk, and a smart person talks about cognitive errors, and we say, oh, that's really interesting. But we actually don't put the study of cognitive errors and how we can make our ability to diagnose better by understanding that into practice. And we're really in the early days of that. This is a seminal contribution, but it's a gold mine, a mother lode that has yet to be fully tapped. What are your errors? You know them better than I do. Scanning errors, failing to fixate in the area of the lesion. Recognition error, fixating in the area of the lesion but failing to detect it. The satisfaction of search error, the diversion of attention from a lesion to an eye-catching but unrelated finding. Intentional underreading, a conscious tendency to interpret equivocal shadows as negative, maybe because of peer pressure. Collegial pressure to produce false positive workups. And that's where external pressures could be playing a role. And you need to be able to talk about this stuff and not feel stupid when you talk about this kind of stuff. I show this one. This one is a telling story. It's a tragic story. It was told to me by a psychiatrist who brought her father to the emergency department of the hospital where she worked, where her father saw an emergency colleague, very experienced. He was complaining of chest pain / indigestion. He was diagnosed with GERD, sent home, and died the next day. And he had an ACS, an acute coronary syndrome. And what was telling to me and what was telling to the psychiatrist went back to talk to her colleague, and not in a shaming way or an angry way, the cliche of the angry family member physician that we all fear and gets us off our game, as you know. She, in fact, the way she verbalized it so beautifully as she was talking to me was that you could tell she was in two worlds. She was in the world of the daughter who lost a father, and also in the world of, I've been in the place of being the psychiatrist looking after colleagues or the children of colleagues, and the pressure that I feel and how awful I feel in those situations. But the most telling thing that I wanted to bring to your attention was that the emergency physician admitted to the colleague, the psychiatrist, the daughter, that I looked at that EKG and there was obvious evidence of a STEMI. And I looked at it but couldn't see it. Now, if the Toronto Star were listening to this right now, they'd say, get that doctor out of here, kill them, kill their career. The problem is they don't understand that you can be the most highly qualified, highly decorated person and in a certain moment look and not see. And I can give you 100 reasons why that's possible. You will be looking at, or I don't know how many of you are doing clinical medicine where something bad happens and I say, I muse out loud, I wish a nurse had brought it to my attention. And then there it is. You look at the nursing notes and there it is, brought to your attention. But if you're not engaged in, if they're not, the purpose of that isn't just to get the information across so that the information's gotten across. The purpose is actually to get a response from the other person. And we are terrible at communication. We are terrible at communication, so much so that we've actually hired outside experts from human factors engineering to teach us how to talk, how to address each other, and how to make sure that when I give some important piece of information that the answer is acknowledged, that the answer it builds in an understanding of what was said so that it's acknowledged and the next action is taken as a direct result. Don't have a lot of time to talk about this because I want to get to the end and talk about a case of mine. In the world of anesthesia, the 3 hardest words to utter when you're trying to intubate a patient in the operating room and you're having difficulty are, I need help. There's nothing more shameful than being experienced and having to ask for help. And this is the story of the wife of Martin Bromley, who ironically is a world expert human factors engineer whose wife went into hospital for routine surgery and who died eventually of brain damage because the doctors in the room, the very experienced ear, nose, and throat surgeons, anesthesiologists, others who gathered to help, failed to recognize the can't intubate, can't ventilate a situation, scenario for which there are guidelines. And right up to the point where a nurse walks in and says, I've got the surgical airway tray, and is completely ignored. And this is part of the transcript of what went on. And there are many reasons why things like that happen. Perseverating on the solution, which is to secure the airway and just run through the algorithm of of difficult airway techniques while the sats were going to 69, 65, 60, 55, 40, and then disaster ensues. That perseveration, maybe it's a fear that all hell is going to break loose when she wakes up with a hole in her throat, but at least she wakes up and she's not, and how much of a shaming experience that would have. So again, there's outside pressure. Let me talk fundamentally about how we approach errors. What did you learn about making mistakes when you were in medical school or residency? Now you're probably getting talks like these. You're getting this course. I love to talk about the baseball analogy. I don't know if you saw my TED Talk. If you did, you know where I'm heading. If you didn't, then you'll hear it. Baseball is filled with statistics, and I like to talk about this guy, Miguel Cabrera, one of the best hitters in baseball, Triple Crown winner. Triple Crown means he led the league in homers, balls knocked out of the park, runs batted in, and batting average. He led the league with a .330 batting average, and I ask you, what's a .330 batting average? Basically, it means that he hits the ball and he was able to get to first base, or he hits a double or a triple or out of the park, and he's able to do that 3.3 times out of every 10, 33 times out of 100, 330 times out of 1,000. You know what they call a hitter who finishes the season with a .330 batting average? Excellent. Do you know what they call a .400 batting average? Legendary. Ted Williams was the last hitter in baseball to finish the season with a .400 batting average. So I ask you, your mother is having chest pain and has been referred to an interventional cardiologist who's batting .427 at angioplasties. Doesn't seem like such a good idea. Suddenly this isn't working out. So the question, though, I ask you is, what's the batting average of an interventional cardiologist or a radiologist, interventional radiologist, or an obstetrician or an emergency physician? What's it supposed to be? And we haven't actually thought about it. The inference is 1,000. That means never, ever, ever make a mistake. Now, how you do that is up to you. We taught you, you graduated, you passed your exams, so you must be perfect. That's kind of the way it goes. And so that if that's your model, nobody ever makes a mistake. So if somebody makes a mistake, you look for someone to blame. Then, well, if you make one mistake, basically mistakes there's two possible explanations for errors. One of them is a momentary lapse of attention, laziness, something you just didn't know that day, didn't ask, a lapse. The second possibility is a pervasive issue. So which do you prefer? Most of us, therefore, sit shaking that a second error will be discovered 3 or 4 weeks after the first one. And I don't have time to play this tape, but Graham Cunningham was an example of somebody, he's one of my mentors, a respected cardiologist who drank alcohol, and he's in recovery, he's been in recovery for a long time, and took pills to mask a deep-seated feeling of shame about his inferiority complex. And he treats, in his career, has treated a lot of physicians with substance abuse disorders related to that very issue. And he can talk to you, he can speak volumes about that deep-seated unhealthy shame that we have. That's our relationship to errors. I promised I was going to talk about my case. I've got enough time to talk about it, and then we'll just wrap up and we'll have time for questions. So, real case, cone of silence. Okay. I saw a 33-year-old male who was intoxicated with alcohol. He was balcony hopping and he fell from a height and landed on his back. He was brought into the emergency department by paramedics at about 5 on a Saturday morning, complaining of thoracic and lumbosacral pain, no other obvious life or limb-threatening injuries. A junior resident on the night shift saw the patient and briefly spoke to the attending who was just doing the night shift. That wasn't me. She noted tenderness in the lower thoracic spine. She noted that he was neurologically intact, and she briefly discussed the assessment and plan with the nighttime emergency physician, and they ordered plain x-rays of the cervical, thoracic, and lumbosacral spines. I came on duty at 8 o'clock in the morning, and the emergency physician on night suggested that the resident present the patient to me to provide full care. Let me talk, and in this case, I'm going to give you the thought bubbles. My immediate anxieties, first of all, me. I did the Saturday shift to help out a colleague who needed to make a trade. I had worked Wednesday and Thursday night, so I finished on Friday morning and I started on Saturday morning. And I slept fitfully during the day, and that night, I would describe myself at that time as alert, though not fully rested, and the old culture of the hospital didn't feel like I was easing into the shift. This seemed like a lot to take in for a first patient. And we have our routines, what happens. And at the time, the usual thing was that the first hour was fairly quiet. Second anxiety, we're not a designated trauma center. We don't have a spinal or neurosurgeon on site. And at the time, it's changed, all the x-rays were read by the resident on call who covered 3 hospitals. Lack of empathy? Do we understand each other? Do we know enough about each other's work? I can remember once in the middle of the night calling up, paging the radiology resident who was on duty about 3 o'clock in the morning, and to order up a study. And he gets on the line, and I identify myself, and he sighs. And there was something about it that touched me, touched my heart, touched my soul. And I, instead of ignoring him and just getting on to the next thing, I said, "You sighed." And you know what he said to me? He said, "I've got 30 pages on my pager from people like me wondering where the hell's the study, or can I get the study?" And you know what? Up until that moment in time, I had no idea what he did. So if we spend a little bit more time empathizing with each other, we might actually get along better. So that was the situation at the time. I'm going to show you these x-rays. I'm going to show them real quickly so that I don't totally embarrass myself. I put some arrows in. Okay. The alignment sort of looks okay to me. My assessment, I diagnosed an L1 fracture. Part of my framing is that I said we're not a trauma center. My framing was that I saw little old ladies with osteoporotic lumbosacral fractures. I diagnosed an L1 fracture. It wasn't an L1 fracture, as we'll talk about in a moment. I missed the C7 fracture completely. I didn't ask the radiology resident to read the films because it often took a long time. I repeated the CNS assessment. Again, there were no deficits. I discharged him with a script for Percocet, and he walked out of the emergency department. At the time, the X-ray reporting system was that all X-rays were to be read within 24 hours. Dictated reports were loaded onto wrists, onto a diagnostic queue that we could access, first by clicking on a speaker icon, and then when it was transcribed, it often took days for it to be transcribed. In addition to all of that, and all of the reports were in yellow unless they were put in red for a reason, either because of a big miss or because of a serious complication, serious issue. And in addition to that, significant discrepancies were to be verbally reported to the emergency physician on duty. So here's what actually happened. I worked all weekend, Saturday, Sunday, no dictated report, no red line report, no verbal report, nothing. Next morning, I arrived for a shift. This is Monday morning from noon until 10 p.m. And the departmental receptionist gave me a message from the patient's mother saying he's in a lot of pain and she wants to talk to me, which prompted me immediately to go to RIS. And again, not transcribed, so I had to listen linearly, and it's hard. It wasn't set up so that you could fast forward easily. It was very hard, and I just listened to this thing in dawning horror. I'll just read the conclusion. There's a loss of height of the C6 and C7 vertebral bodies. Sometimes I just wish that you'd write, "You missed a fracture, you dummy." Just say it. Don't say inflammatory stranding. Tell me what it is, okay? There's a loss of height of C6 and C7 vertebral bodies as at least 3 of the mid-thoracic vertebral bodies, likely T4, T5, and T6. CT scan of these areas may be of value for further evaluation. Severe compression fracture with posterior wall convexity and retropulsion, not at L1, but at T12, as well an anterosuperior corner fracture of L2. Most of those were of no consequence, but the fact is. No report. This was in yellow, so it wasn't heralded as an important report. There was no phone call. And I've often wondered if I wasn't on duty and didn't get the phone call from the mother, how long it would have taken for somebody to have recognized it. Called the mother. made sure he was still neurologically intact, and he was, and advised her to have him return via EMS with full spine precautions. And of course, you know what I was thinking, and I examined him when he arrived immediately, and fortunately, he was neurologically intact. There were many CTs, but this was the money shot. You can see it. This guy was born, he was lucky, and by the way, fortuna, good fortune. That's what separates us from disaster, separates our patients from disaster. We make many more errors than we realize. What separates us from disaster is that not every bad thing turns into a bad consequence. This guy was lucky enough to have a congenitally large enough canal that he could tolerate a lot of retropulsion without nerve damage. He was transferred to a neurosurgeon. I must have repeated his CNS exam 10 times before he was transferred. And eventually, he, several days later, underwent ORIF with a T12 corpectomy, T12 to L1 fusion with humeral allograft. He did okay postoperatively, although he has had chronic pain, probably related to his injuries. Before he left, I sat down with he and his mother and his girlfriend and answered all their questions, told them each and every error I made, including what could have happened from the time he discharged him until the time he brought him back. It was a hard conversation, but I will tell you that as David Amiro said, patients are forgiving if you tell them the truth. What I do differently, I tend to avoid unhealthy shift trades. I give myself a gold star every time I ask for help. Remember, I told you, if I'm reluctant to get a consult, I don't imagine what I would do if it was my family member, because I'm not good with that, but I imagine what I would do if the patient were a colleague of mine. I find when I get into that frame of mind, I'm very good at advocating. And I'm very straightforward, and I just make people do the consult. The system has changed. We have shorter on-call shifts for residents, for radiology residents. X-rays are now formally reported every day, much closer to real time than it used to be. There's much more improved phone and oral contact with the emergency physician. There have been attempts, with Coral, the new system, to improve two-way communication. I think it's got a long way to go. I think the phone, this is more than just a telephone. And the idea of locating has been revealed to be nothing more than a buffer that allows a buffer of time from how long it takes you to return a call. I'm sorry. Residents talk to each other all the time with texting. I ought to be able to text and say, when's the CT going to be ready, and get an answer that I can read, and not have to get the game. I page. And then they radiology, line 5-4, I pick up the phone, or somebody else picks up the phone because they want to talk to radiology too, and then they think they've gotten the call, so they hang up, and then I page them again, and I got a busted phone, so when I pick up the phone, it cancels, it drops the call. You know what I mean? Like 3 or 4 times of this, and everybody's getting annoyed. Smartphones, right? The significant issues that still exist in our system, probably in yours, significant changes between preliminary and final reports, and so that time window during which I have to make a decision can be is longer than we need it to be, and we just can't keep people waiting there for 5 or 6 hours for that final report. And it's not just that it takes a long time, it's not knowing when it's going to be ready. That's a significant issue. Lack of real-time reporting for certain domains, musculoskeletal is probably the worst offender. Interactive X-ray reporting system that we have right now is cumbersome. At Trillium, what did they do? They put in place, to deal with their situation last year, a peer review program for radiologists, and Ontario is instituting a random audit of findings by a second physician. The question I want to ask you is, when you looked at that coverage, did they throw the radiologist under the bus? I think they did. I think they tried to show we're going forward, we're doing this. I don't know the radiologist, but the sense that this all kind of stemmed from one person is absurd. What we need in our system, I think we have to change the paradigm from nobody ever makes a mistake, we all bat 1,000, so anytime a mistake occurs, it must be a red letter occasion. And we assume that nobody ever makes a mistake. So we hit, whenever anybody is caught making a mistake, we hit them hard, we make them scared of the mistakes that they make, and so they never do it again. We have M&M rounds that very often discuss cases in a way that is shameful. And I know some cultures are different. We're really uncomfortable with people who make mistakes. And John Banja once wrote famously that M&M rounds, the whole purpose of M&M rounds is for the supplicant physician to apologize to his or her colleagues for violating the fantasy of perfection. Interesting way of looking at it. Change that culture, because when you're afraid of your next mistake, you don't want to talk about them, you don't want to reflect on them, you're not curious about your mistakes. The system isn't curious enough about its mistakes. When that happens, we are the ones that are applying the brakes to making the system safer than it could be. Change that to assuming that people are making mistakes all the time because they're human, and in a complex system, it's only going to get more apparent over time. As we can do more harm to people, it's going to be more apparent. And when you change that paradigm, you say, what systems can I put in place to make it easier for the mistakes that I know are going to happen to get discovered and dealt with and mitigated before there's significant damage? Assume that good people will make mistakes. And instead of having a system that is almost like putting legs out to trip you up all day, sometimes I feel like I'm running down the corridor with legs coming up to trip me up. Use technology, use wisdom, have reflection on mistakes. But most important, I don't have time for Sully. I have time for this. This is the most important thing, curiosity. Do you know how many mistakes you make? This guy does. Theodore Grancherov. He is a laparoscopic surgeon at St. Michael's Hospital in Toronto, who during his residency was taking golf lessons and discovered that the golf pro videotaped him. And he said, "Why are you doing that?" And the golf pro said, "So I can see what's wrong with your swing and I can fix it." And he thought to himself, "Gee, I wonder why they don't do that in the operating room." And he started to do it. And he has terabytes of himself on videotape. And he's one of the first surgeons in the world to have asked his colleagues around the world to send videotapes, but not before they got together and tried to figure out what's an error. What are we going to call an error? They didn't even know what you call an error. For example, they decided that if, when you're doing laparoscopic surgery, you're operating laparoscopic instruments and looking at a screen, if a sharp-edged object that can penetrate surrounding structures drops out of view, that's an error, because it can do damage while it's out of view. So they decided that was an error, and they got their colleagues to finally decide what are errors, and then he got them to videotape themselves and got blinded observers to score their videos, and he discovered that the average surgeon in the operating room during laparoscopic surgery makes 15 errors. Well, that's a far cry from batting 1,000. He's also developing the world's first flight data recorder for the operating room. Now he's working with Air Canada. And I call him the most dangerous man in medicine because videotaping, now videotapes cannot show certain aspects of context, but I think a lot of us are afraid of being videotaped, and we cite things like privacy, but the real issue is that we're afraid. I want to leave you with one thought. If we have time for questions, happy to answer them. Be curious about your mistakes. Every good thing that I have ever done on this earth has come one way or another from a mistake I've made. Thank you.